Welcome to CoROM Conversations for March 2026. My name is Aebhric O'Kelly. I'll be the one that walks us through this, but I will need a lot of help from our other hosts. Bill, you can introduce yourself.
Hey, Bill Vasios, I'm a PA.
And
Hi,
Rhod.
Rhod Jordan, I'm a paramedic.
So I wanted to have a discussion on how to create an ICU in a jungle. And there's a bunch of different locations we could have chosen, but I wanted the jungle because that is just adds a whole bunch of extra pain. And the premise here is one of our graduates, paramedic graduate or master's graduate, is working for MSF or working for World Health Organization or for a security company, and they are there for medical support. We have quite a few of our graduates that's done BBC work, so there's filming in the jungle, and their job is to keep everyone safe. So this is the premise that you as a paramedic or junior doc or nurse is following around a BBC crew in the jungle. And so you have just your normal medical kit. So let's have a chat about that. All right. So site selection. So I have a picture here of hammocks. And for a jungle, hammock is a good option, and even other locations. I don't know, Rhod, do you use a jungle if you're out in, or a hammock if you're out and about in herbal for having an overnight somewhere?
Not so much in herbal, mate, but previously in Guyana, Central America, very much so.
So you're going to have a hammock that you're going to be in, and your team or the BBC crew you're with are going to be in a hammock. So the hammock is going to be your ICU bed. And so your job is to select the site on where you want to set up your team. So what are we looking for as far as setting up this remote site in, let's say, Liberia in the jungle, and your BBC crew is having a documentary on tree frogs? So what do we need to think about with site selection?
If nobody else is going to jump in, I'm going to have to, because I can't leave you in silence, mate. So good overhead coverage, decent floor, so you've got some kind of drain away. Particularly with the thinking jungle, we need to think about the amount of rain that we get, so that's got to come into account. And then all the local creepy crawlies that come into it as well.
Yeah, Lassa, go ahead.
Yeah, I would say like all the things from nature environment in general. So everything like wind, rain, dust, animals, like everything which can like disturb our patient or increases infections, for example, or even cause hypothermia.
Good. So we're in the jungle, and people don't think about hypothermia, but it could very well be hypothermia that you have to worry about. Good. So mosquitoes, mosquito nets were mentioned. Absolutely. You have to deal with the wee beasties, the dengue mosquitoes during the daytime, and the malaria mosquitoes at night. So you're setting up your clinic. What do we need to think about? So you have your tent and kind of off to one side. You're not in the middle of where everyone else is, because you need privacy if you're going to have someone walking in to your clinic hours. So how are you going? You have a hammock, you have your backpack. What are you going to do? How can you create your jungle clinic?
You need a machete so that you could cut down enough bushes and foliage to create some kind of screen or, barrier to give you that privacy. You need trees that are strong enough to hang your hammocks.
Good. So
I
yeah,
think,
go ahead.
yeah, can I, yeah. So I think we have to also think about the location of the thing. It shouldn't be in the, like a river base. It should be elevated enough to prevent from flooding, like especially places that rain is pretty strong and can cause flooding. And so the location of it should be also, at first, should be considered, like, because there are some geographical or weather difficulties, but with the location we can prevent or minimize.
Good. So you definitely want to have it away from the swampy area. We want a slight incline, so when it rains, the rain doesn't pool around where you are, and you do want to be separated out a bit. One thing that I like doing is having a reflective tape, and I will hang that from, it's a meter long, is hanging from my hammock string. And everyone, when we first set up, I'm telling everyone there, look, see that hot pink streamer that is reflective at night? That's me. So at 3 a.m, I don't want people wandering around trying to find where's the medic. So one thing is you got to kind of be off to one side to have privacy, but you need to be findable. What do you guys think?
Definitely thinking a lot about lighting as well for the night, and how we're going to be able to get enough lighting for, like you said, be seen, but also to be able to see.
Yeah. So what can you do with that? How do you make lighting?
So you use your side looms, color code your side looms, explain the green path that goes to your toilet area, the red side loom for the medic, but make sure your people are briefed.
Yep. Lasso, your hand was up.
I was just thinking about like accessibility in general, for example, for medivacs or other things. I mean, it's also good that we are like protected, but we also have to be accessible for like further resources.
Good. Good.
Hey, Rick.
Yep.
So I think backing up just a little bit, I think you want to identify all of the different things that you're going to do in your clinic. So you have a clearly marked and identified entrance. You have your processing of patients and triaging them. You might have an area for your regular clinic, your normal sick call stuff, maybe some area set aside for your trauma, and then some for your more serious patients that you're going to maintain and sit on for a little bit longer. So I think you've mentioned it before about zones, like setting up different zones that you want and have that in a logical flow pattern through, so that the most common things that you're going to do, the most frequent things are going to be the easily accessible, and then the others you're going to have access to and control to, with all of the other environmental factors: protection from the rain, protection from the wind, protection from the mosquitoes and the other stuff. Having enough poles that are sturdy to hold up all your material and supporting devices. So I think kind of laying all that out, and then, like everyone said, clearly light it, clearly identify it. Give somebody a focal point to key in on when they want to reach out to the medic, so that they're not stumbling through the rest of your stuff, jacking up what you've already clearly labeled and set out. So I think all of those things, but just kind of clearly identifying what you want to do, and then where is that located in your clinic, so that you and your people can get through there without the lights. Because when the lights go out, it's going to happen. How do you navigate that area? Does it make sense logically?
Good. Pangi?
So, Bill, how do you determine whether or not you're going to have multiple areas versus one? Like, I mean, if I'm planning on having coverage for enough people to where I'm going to need multiple beds ready, versus, reactive to like some sort of MCI type situation, then I feel like I should be having multiple of me, if you see what I mean, multiple providers. And what would you say is your sort of your bandwidth? Because I mean, that's going to all come back to the initial risk assessment, determining how many people you need versus how many people you're going to be treating. So like, I don't know, is that like going to be one sort of quote unquote bay per provider? And then also, just a side note, I was just, when Aebhric was asking about how to produce lighting at the site, I haven't done too much jungle time, but I'm assuming there's an inordinate amount of insects that get attracted to light. So do you guys recommend like lanterns or headlights? Because the headlights will be moving, but the lantern will constantly, I don't know how, sorry.
Yeah, Tenga, you had about 10 really good questions in that burst. So going back to the beginning, I've never had the luxury of having more than one medic on my team. And so somebody mentioned as a comment, I think Rhod, train your team. So you definitely have to identify that one other person that has the capabilities to become an assistant medic, like the first assist medic that's not a medic. And then you train everybody else up to, a basic level so that they are assets and not liabilities when you do have one of those mass cal situations. If it's just me working primarily, I'm going to have that one main area where I'm going to attempt to solve all of the majority of my problems patient-wise coming in. I'll have anticipated the most likely things that I'm going to encounter in whatever environment I'm going to be in, and then the most dangerous. And so I would ideally like to separate those two. I would like to have one smaller controlled access that I do most of my stuff. And then if I have a really sick patient, I'm going to have one separate area that I can put them off to easily access myself or with my first assist medic, non-medic, to be able to assist me. And then I can handle the majority of the other things in an area so it doesn't interfere with what I'm doing with my critical patient. So if it's just me, I'll probably split it up into two clearly identifiable areas. But if I have additional medics, then I can obviously expand upon that. But my plan initially would be for me to do it myself with whatever my teammates that I've trained up to their levels.
So Bill, would that be like a chair versus a hammock? Chair for 99% of things, and then when you have your critical, you're going to do more of a supine situation with.
Yeah, I think whatever you have the most of. So I a lot of my jungle experience is in the Caribbean. So as tragic as that was. I carried a hammock with me. I had multiple hammocks. I had one hammock that was always in my ruck and always on my belt that I could pull out and just hang between trees because I never wanted to lay on the ground because there's always some kind of bug that's going to crawl in that you won't find out till later. And then I'd have the more elaborate hammock that was nicer, the Cadillac version that I could lounge on when I'm not working or when I'm laid up doing nothing. But then in my clinic, I would bring cots, those shoddy green cots that are, takes you years. You need a PhD to operate and put in. So you lock in both ends, or you're an engineering genius. And I'll have those as much as possible. And then for the patients, because one, it's convenient because you don't want them having to try to navigate getting out of a hammock to spend, if they have any kind of physical limitations or injuries, you want them to be able to bathe themselves or, use the latrines themselves. And trying to get out of a hammock if you're injured that's kind of fun to watch if you're actually sadistic. But you want to make it so it's easier for them to navigate in and out of their cot or their bed if they're going to end up staying for any length of time. So I wouldn't use like the picture that Aebhric had up about the hammocks and stuff. I've never been able to manage a serious patient in a hammock. That's always been for comfort or sleep, but I would put him in a cot.
It depends on the job. So for this one, say you're working for BBC, you got to have everything out of a backpack, and you're walking 8 hours past the SUV car park to see this tree frog. You're not going to bring cots, but you could bring. I'm with Bill. So multiple hammocks are awesome, and I'm fond of the Hennessy hammock for myself. It's like a hotel. And so you ask about chairs. Yes, absolutely. 99% of our clinic time is austere primary care, right? And that's going to be and they have their own chair, so I have mine. You know, you want to come in, my sick hours are this, bring your chair, sit down, get away from everyone else. Let's sit down. Where's your itch? Okay, let's talk about that. That's going to be a sit down sport and not necessarily a hammock. So you got both ends on that one. Good. Any other questions on the physical layout? Now, let's start talking about fun stuff, toys, monitoring. So there's a minimum, better, best that the Long Field Care Working Group uses. Fantastic. But let's just talk about the minimum. What do you have on you? What in your backpack? And what do you have in your SUVs? So your ruck truck house. So for me, I have a 3-lead ECG. That 3-lead ECG, that's my arm. I'm a big fan of having that capability to get a 3-lead, and that's an SpO2 as well. And we use cling film to put it on top of the BP cuff, which something you need as well. So for monitoring, I look at CPRO. CPRO is our primary vital signs at the college: cap refill, pulse, respiratory, and oximetry. And with that, I have an instantaneous look of the cardiovascular capability of my casualty. And then I can add on to that. But so I do carry an ECG on my computer bag. I even carry BP on my computer bag because it's super compact nowadays. Steph, not so much. So what do you guys think you would have on your minimum, better, best for monitoring in your jungle ICU? Yep. What do you got, Lasse?
It's the same like on the wind turbines. I think I would go with BP cuff, SpO2, and the stethoscope. I think this would be my minimum. Or maybe not the BP cuff if we have like capillary refill for the beginning, but I would not feel comfortable without it. Like ECG is for me like better. It's not minimum.
So BP is mandatory.
Lasse, you would rather have an ECG than a BP?
I would prefer if we're in this situation, and I would prefer the BP cuff to the ECG.
Okay, sorry, I thought you said the opposite.
Okay. Sorry.
So we need BP because that's our map, right? In austere ICU and critical care, it's all about urine output and map. That's we have to have. So on the basic, your minimum, better, best of your monitoring, the minimum, yeah, maybe having a BP is mandatory because we need map, don't we? Anyone else?
Well, I'd say we like map more than we need it. Right? I would put it into, I would like to have a map and I'd like to be able to chart that over time. But my confirmation that I have a sustainable map is urine output, mentation, perfusion. So I'm looking at lag measures versus lead measures for that. And if I'm carrying everything in, if my BP cuff crashes, I can still determine whether they're perfusing because I can have a conversation with them, check for mentation. I can check and monitor and chart their urine output. I can do all those things. Two things that popped into my head were everybody's got these smartwatches and they all kind of do a lot of monitoring. So if there's a way to kind of harvest what each individual is likely carrying, if it's the BBC crew with that scenario, they probably got some watches. They might be fit enough. They have all their apps that are tracking those things. There's be a way to kind of harvest what they're already carrying. So that's less equipment for you to carry using what's out there. But if I were going to carry a personal tool, it would be some form of portable ultrasound. Obviously, I'm a fan because that gives me a lot of information. I can check so much and get instant feedback on efficacy for perfusion and flow and any of that stuff. So if I'm going to carry a Gucci tool, it's going to be a point of care ultrasound device.
I definitely agree with the ultrasound. This is what I had for a minimum, and I had ultrasound in the better option. But I'll be honest, I carry ultrasound pretty much everywhere that I can. Would anyone add anything to this minimum page? I'm glad, Bill, that you mentioned the clinical monitoring. I mean, we are medics. Don't forget that the skin perfusion or the modeling of the skin is just, as you can monitor how badly your casualty is in shock just by touching the skin and feeling the difference in temperature. So good. And then for better.
Aebhric, I think that lighting needs to be mentioned one more time, because we've all been in a situation where you have all of your stuff, but your light either goes out or you can't see it, and it makes things a lot more difficult to do that monitoring that we're talking about.
Lighting, yeah, there's a slide at the end. We'll talk about non-medical kit. And to quote Jason Jarvis, 2 is 1, 1 is none. If you have one light source and you lose it, you're up a creek. So yeah, light source is really, really important. I have 3, and one of them is my smartphone, but you're absolutely right. And then the best option, if you have a life pack 12 or yeah, go ahead.
Well, I would say I would go back. That's along the watches. Everyone's got a watch. Everyone needs to carry multiple light sources too, for everybody else. So you're kind of distributing that amongst everyone, and the odds of everyone's light sources going out at the same time is less, but still possible. Yeah.
Good.
In this case, for light sources, like 12 is 1.
I'm a complete freak, I guess. In my day sack, my travel pack, I have 3 different torches. That's just the way I roll.
Let's talk about drugs a bit. What drugs would you change if you're going 8 hours past your SUV with a couple of old guys who are entomologists studying some sort of BBC documentary? So what kind of drugs would you want to add to your normal kit?
A JP8 and a helicopter.
Yeah, triple
my
canopy.
preferred drug.
Yeah. Lassa?
I think it depends. If I have this mission, I think I would go more to primary care stuff. So like pain NSAIDs, like painkillers, some things like cream for insect bites, like all that kind of stuff first, and then have my like normal emergency medication kit with me, like extra.
Good. So yeah, next slide that we have over-the-counter stuff. We're going to talk about that. Everyone wants ketamine. Everyone loves ketamine and Medaz. I'm one of them. But on deployments, very rarely do we get to play with the fun stuff. It is the basics, the over-the-counter meds. So what do you guys carry that you're something over-the-counter or primary care? What kind of drugs would you want to add to this trip?
Activated charcoal, and one that is not a drug, but I think is the most useful thing to have, betadine for disinfecting.
Good. I'm a big fan of Dakin solution, which is a powder that turns into yeah, go ahead, Lassa.
I think it's mentioned already.
Okay. Tange, yeah, these pill boxes are given out to everyone and coming through now. I donated 200 of them, so you're more than welcome to them.
Appreciate it. I would. Has anyone used the new, well, new in the US at least, non-opiate analgesic. I think it's called I'll Google it real quick. Has anyone used it yet? It's a new OT. It's oral pill. I'll have a look.
Alejandro, yeah, antidiarrheals. I'm a big fan of loperamide, but only for a social reason. Loperamide is a social drug, meaning that unless they need to be exfilled or they go to a meeting, if you're security for some big wig in the area, you need loperamide. But the Wilderness Medical Society showed good research that loperamide doesn't extend, nor does it shorten the disease process. Anyone else? Yeah, Lassa.
I think just in general, from my experience remote, like the most things which I give at the moment is painkillers and stomach stuff. So in general, that's like the most common part. And I think if we talk about like this, as you said, like one day or 2 day trip, I think loperamide is not a bad idea. Of course, it's a social drug, but I mean, we also have to, so if you look at this like strategic, you also have to get this guy out with you out of the jungle, and maybe it's a reason to like give loperamide for the first day till you're back in like civilization again, and then stop it.
Good. Somebody mentioned a Z-Pack. That's good. Anti-malarials. This is something you need to be fastidious on, but not just for yourself, but for all these BBC people who don't understand malaria. And I'm too lazy to carry a severe malaria patient 8 hours back to the SUV. So yeah, every day you got to get into a group. All right, everyone, show me your Malarone, and everyone take it. Good.
I think to add to the analgesia, you probably want to think about some Penthrox or something like that.
So that's not bad, but the problem is we're 8 hours out, and you got 2 doses with the Penthrox. But unless, yeah, if you're reducing a dislocated shoulder, Andy, you're right. A fantastic drug for that. Anyone else?
Yeah.
Docs
for this case, I think
to cover malaria. Good.
Sorry.
Go ahead, Lassa.
I love what Marlon said about ORS, but I just wanted to ask, I've heard activated charcoal 2 times now, and I just want to know people's arguments behind that.
Yeah, there's some research showing that it's not the best option anymore.
Activated charcoal
let's
without
talk about that. Say that again, Bill.
I was going to say activated charcoal without an NG tube in place. I've never had a patient drink activated charcoal. Yeah, I've always given it through an NG tube, and yeah.
So what about dermatology? What kind of meds do you think we're going to be dealing with on a day-to-day basis for these BBC guys? Good. Antiemetic. That's why I have the meclizine there. The antiemetic is a good, or indazapron if you have that. I'm a big fan of that. I carry that myself. Any other derm ideas? Doxy does cover skin and malaria. It does. Go ahead, Lassa.
Hydrocortisone, then like panthenol cream in general, like for rushes, whatever. Something against herpes. I don't know like the name, but like this kind of environment is like a good trigger for this. And some kind of antifungal cream for like athlete's foot, for example.
Yeah, I'm a big fan of the Gold Bond powder for athletes' feet.
I think a lot of the anti-malarials, the antivirals. If somebody's got a history, well, let me go back up. If we're in a malaria endemic area, everyone's responsible for their own. I would like to know everything that everyone's taken, because what I'm going to carry is going to be the treatment for them if that fails. And you can't typically use the same medicine to treat if they're using that as a prophylaxis. So you'd have to know which medicines that they're taking for anti-malarial based on the location. And then as the primary medic, I would be responsible for carrying something to treat them should their prevention fail, whether it's compliance, most likely, or resistance, right? As the provider, I'm going to need to give them something stronger than what they're already taking for prophylaxis. And then for any of their other endemic medical conditions like herpes or whatever, for flare-ups, they would be responsible for carrying something along those lines. I would put the initial response on them to carry their prevention and rescue meds for something like that. I would like to know it so I could carry some additional in case, you know, their meds get destroyed, whatever. But that would be like a pre-screening for whatever crew that we're traveling with, if you have the luxury of doing that. If they're coming from multiple locations, the likelihood that you're going to run an effective screening for all of the people is less likely. But the goal as the provider would be to try and have some type of pre-screening for everybody that's going to be on this excursion, so that you're aware of any endemic medical conditions that may flare up or cause you concern later, because they're going to wake you at 3 a.m. when that happens.
What about infection control?
Soap.
Tanguy, I think you muted yourself, brother.
Soap.
Oh, soap. Got it. Yeah, I'm a big fan of hand washing. Semmelweis is correct. Anyone else?
Eye protection and
solution?
masks.
Good. So if you have respiratory problem person coming into your clinic, yeah, you might want a mask. Good. And don't forget Dakin solution. It's super lightweight.
That's actually a great point. How do you guys manage your glove usage on these types of expeditions? Because I mean, if you're doing wound changes every 12 hours, night and day, you're gonna run out of gloves. I'm not carrying a whole box of gloves if I'm just carrying a backpack. So I mean, I'm just expecting to be washing my hands and just not using gloves unless I really, really need to. I don't know if you guys are just bringing sterile gloves for sterile procedures and just otherwise not really using gloves. What are you guys' thoughts on that?
Wash your hands, mate.
Yeah.
I think it's like the same. I think this is like this typical paramedic nurse thing, because you all know like nurses are, so paramedics are using gloves every time they touch a patient. But if you ask a nurse in a hospital, like, when is this nurse like wearing gloves? Like the half-time of paramedic.
Yeah, also, I think in an environment like the jungle, you'll be lucky to get a pair of gloves on your hands in the first place, because it's so humid, sweaty and hot, you know, you're just dripping wet all the time. You'll never get a pair of gloves on.
Yep. So back to soap and Dakin's powder, Dakin solution powder. So what about power? So you need to, yeah, go ahead, Bill.
Well, I was just going to say sterile procedures in the jungle are a goal, but it's never going to be what you actually get. You're going to go for as clean as possible, and then rely back on your antibiotics to cover some of that inevitable contamination. I mean, you would like to have it as sterile as possible, but some things you're just not going to be able to get.
You definitely aim for that, though. Evidence-based medicine works everywhere. But
oh,
yeah,
absolutely.
Trying to get a sterile
the goal.
field
The reality, it's the goal, but the reality is, yeah, you're going to be sweating. It's going to be wet. It's going to fly into your field. It's the goal, of course.
Cool. So what about power, food, and water for your jungle ICU? triple K, you have a lot of. So one thing is sometimes you have to scout around, find some clearing maybe that's not in your immediate AO, and leave your battery and solar charger there, or at some rock outcropping that you can climb up a bit to get a little bit of sun. And that's where, well, first off, that's where you're going to get your SATCOM for your top cover. But you may have to set up a charging station away from your clinic, away from your camp. And water. How do we get? Yeah, go ahead.
I was going to say, I've never gone on a BBC excursion, but I suspect with all of the cameras and such, they're going to have a good plan for charging all of their cameras and their stuff. So, I mean, that's probably going to be one of their primary goals, and something that a problem that they've already solved. I think just being aware of what it is and letting them know when your needs are going to trump their needs, at least have some kind of an agreement set up to charge your devices. But you should definitely have battery backups and solar options and all of those things.
Absolutely. And having a foldable solar panel is mandatory for a medic, because your handheld ECG, as nice as it is, it's not going to charge itself. And what about water? How are you going to get drinkable water for your clinic, for your ICU? I have options that I've used. So the Catadine filter is definitely something that we had on the teams and the ODAs, and I've had on my wilderness expeditions. But boiling water works. This is a Kelly kettle. No, I did not invent this. Another Irishman did. But every ICU should have one of these, because you can cook with it and you can boil water very quickly with just a little bit of dry wood. So we cannot talk about an ICU in the jungle or an ICU anywhere without boiled water. We use a ton of boiled water, and it's more than just a cup of tea that Mrs. Doyle from Ireland keeps talking about. A cup of tea does make the world a much better place, but we go through a ton of boiled water in an ICU. So this is something you need to think about. What do you guys have now that's going to get you boiled water?
Like at home?
When you're out and about in a backpacking or wilderness environment, jet boil, good. That's common and so convenient, but you do have to carry your own fuel, don't you? And then once you have the water boiled, where do you keep it? So when you start thinking about an ICU in austere environments, it's more than just having a bunch of ketamine and a Foley kit. You have to think about how to have a nursing station, how to reuse bandages, and you can put them in a pressure cooker if you want to carry that, or boil water and then put them out and let them dry. It's not the best, but it works. These are things you have to think about when you are thinking about an ICU. Any comments?
I don't remember who said it, but I love Bill keeps bringing back to it of like, it's a team approach. We're not going to be the only ones helping the rest of the team. And everyone having, there's one person in charge of water, and that might not necessarily be you, but could be you, and making sure that everyone's doing things in a sanitary manner. But the idea of having someone who's filtering, e.g. via like a millbank bag or another method, or pre-boiling, or instead of spending so much time for doing that for 10 people every day, you just filter and you have clean water, but then everyone sterilizes themselves pre-use, making it a lot smoother. But I don't know.
These are things you have to think about as a medic. If you have 7 people on your team, on your BBC group, how are you going to maintain that they don't get unwell because of what they drink? Zach, you'd mentioned UV light. There's a ton of different ways to make potable water, and much like a torch, much like a light source, 2 is 1 and 1 is none. So I carry a life straw. They're rubbish, but that's my go to hell option. And then I have a cat-o'-nine filter, and then I have a way to boil something. So you need to come up with a ton of boiled water. And I wanted to mention bushcraft. I used to teach bushcrafting in Kerry, Ireland, ages ago. I was a bit younger at the time. And I encourage you guys to look at bushcraft skills as a benefit for being a remote medic. Like you need to be able to do a quick 5-minute fire, to boil something, to be able to get bandages moist. You're going to try to wipe the guy off, and you don't have shaving cream to make it easy for you. And so you need to come up with ways to be good at bushcraft, which is basically setting up your camp as well. So I put up my Hennessy hammock, and I tighten it so much it's nearly flat, and then I get 2 sticks and I pound them into the ground right where my feet drop out underneath the when I come out of the Hennessy hammock, and my boots are on those 2 sticks upside down, so I can always find them, and they're not going to have a wee beastie. Oh, they still have a wee beastie in them for once in a while, but like campcraft is really important if you want to be good at an ICU, in a jungle ICU. So you want to be a remote medic. And I'm sorry I didn't put bushcraft skills, survival skills into our bachelor's program. We had that discussion, but you need to be good at campcraft if you want to be a remote medic. Any thoughts?
I concur.
No, that was absolutely perfectly and passionately put.
So I have a whole series on the second one on the list. At the end of the list is medicinal plants, and that's one of my passions, is finding wildcrafted plants that can help you out. And we'll be talking about that at our workshop at SOMA. We have the Improvised Medicine SOMA workshop at SOMA, and we're going to be talking about how to make meds. And then the last one, I don't know if you guys know what a rabbit stick is. Rabbit stick is the first thing you grab when you're in a bushcraft situation, and it's basically just a stick. And whenever you come across a rabbit or a bird, you chuck it. And surprisingly enough, the rabbit stick is pretty good at getting stuff. So we talked about Kelly Kettle. Now, you as a medic, how are you going to communicate? Pictogram. So you need to think about inter-team communications. I'm dusting off my old 18 Echo thinking here, but I'm thinking also comms back to your medical oversight. So you obviously you need more than one. You have a PACE plan for communications. So do you have a sat phone, or do you have a mobile phone to back up that sat phone, or what options do you have in the jungle with triple canopy? When you have your site, when you talk to your BBC crew and they point to you on the map, point where your location is, you need to get that terrain map in and see where's my high ground. I'm going to recce my high ground, and that's where I'm going to go to get my SATCOM through, because triple canopy, you're not getting any satellite communications at all. I was a pretty good Echo, I think, but there's no way I'm going to get through triple canopy. HF, oh hell yeah, I could do that, but we don't do that anymore. So
I would modify your statement just slightly and say you're going to send somebody to make commo. As the medic, you're going to stay with your patients.
Fair
Not
enough.
the Echo anymore.
And now you need team communal. So you're setting it up to the overhang, the outcropping of stone and rock that gets high enough for him to get through. And now you have to have a walkie-talkie or some UHF communication to talk to him. But you know, as a former 18 Echo, we'll be here all day. So let's keep going here. Now, you have this guy. It's 8 hours to the SUV, and we are dealing with prolonged casualty care. We need to go through our hitman and chief vomit. What are you gonna? We're talking about an ICU in the jungle. What kit can you think about now before you get into that situation on what you would bring to help you with your prolonged casualty care?
A Foley.
So if you're going to bring a Foley, which you should, you need a Foley kit with sterile gloves and a drape. Definitely. Good. What else?
You also need to entertain the idea that you're gonna have just a couple of straight caths that you will go through the cleaning and sterilization process with, because you're only having one or two of those. Well, and then the other part too is, at what point will an injury or an illness derail the mission and then you initiate the signal to exfil? Like, we're not going to continue with the last 4 days of our plan because one or two people have gone down with an injury or illness. And so now it's index. How do we initiate that? Like, the goal isn't to take care of this person and drive on. The goal is to, okay, now we have to leave. We're done. Right? What is that call? Who makes that call?
Yeah, and that's the difference, I think, with doing this with the BBC compared to an ODA. BBC is like, oh, I stubbed my toe, I'm out. That's that. I'm done. And that's the, yeah. So, but for us on the ODAs, we have a mission, and we have to continue. Yeah.
Well, you still had, at what point was the team non-mission capable now? Whatever your mission was, at some point with enough injuries, you can't do the mission. So that call has to be made as well.
Yeah.
Yeah. Not an easy call, but has to be made.
Yep. I made it. We're getting close on time here. I made a whole bunch of non-medical kit as stuff that you might want to bring that you might not think about bringing. I would like to mention the Woobie. Now, there's a special relationship that all Army guys have, operational guys have, with a Woobie. A Woobie is a poncho liner or some sort of, I have a wool blanket that is my Woobie, because wool will keep you warm even when it's wet. And I still sleep with it, even in the flat in Germany. How many of you guys have Woobies, or is that too personal? That's too personal. I understand.
No, it's fine. I've still got mine in the back of the Land Rover. Even having moved house yesterday, I've still got it with me, mate.
Nice. Nice. Awesome. Awesome. We'll keep the Woobie stories aside.
Okay.
Yeah. On the stressful nights, I still like to.
So, and Rhod,
don't put that on the YouTube bit.
No. So you had a really good discussion on a smog. So you have a Woobie for warmth, and in the desert you have the schmog, which is keeps you the sun off, which you can use a Woobie for as well. But so in some places you have a Woobie and a schmog, a cotton sheet that you use as well. Good. So just don't forget the non-medical kit. Don't focus just on the medical side of things. Make sure you keep your basic tools that you need. Have backups as well. In the jungle, the folding saw, and I have a Japanese one that has a super thin blade that only cuts when it pulls, and it's awesome. It's well worth the 40 quid. So having things to make your life easier when you're in a jungle ICU is really important. It's not all about medicine. But in this situation, if you're with a BBC crew of 7 or 8, you should plan for at least 2 casualties. So that means you might need 2 hammock setups. You might need to have kit to maintain them as you exfil over 8 hours to the SUV. Because you might be, if we're in West Africa, the malaria is rampant. You can have 2 malaria patients. And so it's really important to make sure that you have the capacity to have a 2-person ICU in the jungle. Any thoughts on that? Cool. And that's all I got. Any questions or any comments?
All right, Rick, I like the
Can we
discussion.
talk about the bugs and the lights?
Yeah, so there's no way to get the bugs out. So what I like to do is I have a head torch that's super bright, and I'll get my Nalgene bottle and I'll strap that head torch so the light pointing into the water, into the Nalgene, and I'll put that on a table, or I'll hang that, and the bugs will go there. And then when I'm walking around doing my personal stuff in my area of the camp, when I need a light, it'll come on and off. I'm not going to walk around with a head torch on all the time, because that's just a target. But by having a brighter light, and for some reason a head torch shining into a Nalgene with water is awesome. It gives you plenty of light, and then all the EBCs go in that direction. But does anyone else have other idea of how they deal with this?
Does red light affect them?
Yes, the red light, they'll follow red light as well.
Okay, thank you.
Yep.
And if you get yourself an arc light, which has got a UV capability, you can scan for your scorpions and bugs as well.
Nice. We didn't mention that in the kit. That should be the minimal kit to have an arc light.
Yeah, absolutely, mate. We dropped the ball on that one.
So any other questions or comments on setting up an ICU in the jungle? I'll arc light. I'll set. Rhod, can you put a link to the arc light in the show notes, so people can see what we're talking about? Just the arc light website.
Yeah, stand by. You know I'm a bit of a fan.
Yeah. So does this change anyone's concepts or ideas on how to plan to set up an ICU? Zach, you've been quiet, brother. Do you want to say anything? Because you've got experience in this as well. Is he still
Sorry,
here?
trying to.
Yeah.
Yep, you caught me in the middle of trying to eat there. I think one of the biggest things you need to do in the austere environment is plan. You should have, as Bill talked about earlier, you should be able to have done a full past medical history on everybody who's going with you, and so you should know what they are, what they're going to be susceptible to, and also to convince them to bring those extra medications that they take for their daily lives. And I've done that with packing around the jungle with a 70-year-old man, who had a pretty dense history, all the way to being with just young 20-year-olds in the middle of a different jungle. So that's one thing I would recommend. And also the planning for evacuation of how you're going to get back. Each mission is going to look different by whatever you're doing. BBC with the crew is one thing. I've done anti-poacher operations in the middle of the jungle, and that was quite different. We were running around with a very light pack and crew, so what my ICU looked like that had to fit within a small backpack to be able to carry around. We were limited to about 45 pounds a person. But you have to have a plan to be able to get back. And so, okay, well, maybe the whole ruck truck house model is how you're going to work that back. And it was at least typically 20 hours before I could get back to a place to where I felt comfortable, where I had enough stuff. And as you go, you have to build within capability. And so that's important. So I saw someone just posted in the chat of what about a ventilator? A lot of times you can't run around with a ventilator. I've done recovery rescue operations where I've come in to extract somebody, and I've had a small ventilator in my backpack, but I had a helicopter that was essentially going to hover around me till I'm ready to go. But that's hard to bring with you. Battery life, there's multiple things. And the drugs to maintain them on a ventilator is extremely difficult. Do they need paralytics? Or even if they don't, if you have a GCS low enough to be intubated, it's not going to be likely that you're going to survive. Even if you have to get a crike in there, probably not going to survive if you require a ventilator. And then, let's see, I already know I've gone too long here, so I'll try to wrap this up. But plan your whole way back, being able to slowly elevate to what you can, slowly building within what you're able to do. I liked what Bill said about everybody's kind of part of the medical plan. Everybody carries things on them for medical. Usually, like a lot of people carry things on them for communications. But a basic first aid kit on everyone is a smart thing to do. Their medication that they daily carry. And I'm trying to think to the back end of it. I can talk about the higher end ICU stuff that we've gone and fixed in there, but you can get very remote out there. Also look at what environment you're going on. Just because you're in a jungle, everyone wants to think of flat jungles. There's a lot of jungle environments out there that involves the mountains too. And so consider what you're going to do and how you're going to move patients in that environment, in the different injury patterns that you're going to see. I've seen quite a bit of that too. And dealing with a head injury patient in the middle of Laos is not an ideal patient to have, but I'm already going too far, so I'm going to step off of here. If anyone has questions, you can ask me on the side.
Awesome.
Yeah, I would
Thanks
agree
for
with what Zach just said about planning ahead. I'm out here in Tanzania right now at KCMC, and the amount of people that have come off of that mountain with AMS or HAPE and HACE, and none of them are taking any sort of prophylaxis. And you think to yourself, why would you come out here without any altitude prophylaxis? But they just don't, because their tour organisers don't think about that and they don't plan ahead. So I think that's quite an important point. Malaria prophylaxis as well, and IFAK, as Zach said, is pretty much essential for everybody.
I think one thing to kind of add on there, good seeing you, Zach, is a lot of the decisions to stop the mission is going to fall on the medic. And you have to decide, okay, is this patient so sick that I have to be stationary, and evacuation is them coming to us because this patient isn't stable enough to take out with just one person, one provider. You need a team to come in and get that person. So being able to correctly assess and make that determination and then turn around and brief that to somebody so that they understand the patient is not stable enough to be carried out by the one person or the team of non-medics to get out of there. They're going to have to send somebody in to get them. That's another call that needs to be made specifically. So you're going to set up the ICU because you have a sick patient, and you're going to be stationary for a while the team comes in and gets that sick patient because the patient's not stable enough to take out on your own with the people that you have.
Awesome. So yeah, we're right now at the top of the hour. That is the discussion. Any suggestions for next month?